is a blind disease that can damage the vessels and cause all the broke of the hematoretiniana barrier and can have all this inflammation and destroy all the vessels. And this broken in the hematoretiniana barrier can cause swelling, and this swelling can cause loss of vision. And nowadays we have lots of ways to treat diabetic retinopathy. We use lasers, to use injections, steroid, or vitrectomy. And all this treatment, how to decide to use laser, anti-VEGF, steroid, surgery, and what's the biomarker that's going to help you to decide what the best treatment for each situation. And ETDRS, that was more than 20 years ago, guide us for many years how to treat macular edema. After use the laser, reduce 50% in the risk of vision loss, but only 25% really gain vision with laser. And this table with all these trials can tell you that lasers works, but if you compare with the other treatment with injections, it's the one that we can gain less vision, but does work. And if you ask me if I'm still using laser for macular edema, I say yes, especially if you have a focal leakage of the vessels. Laser work very well. It's a very inexpensive treatment, and you can last for many years. And this protocol, everybody knows this protocol. This tells us that if you compare laser with the anti-VEGF drugs, we can gain much more vision with anti-VEGF drug. And if you add laser, maybe it's quite the same. They have little letters difference, but in the practice, many people add laser combined with anti-VEGF. And the good thing about anti-VEGF in diabetic macular edema is this. The first year you have to inject a lot, 8 or 9 injections, but after that we're gonna use less and less injection, and sometimes some patients you get stable and we don't need to inject anymore and we don't have any edema. And protocol T was quite curious because they compare the 3 drugs that we have to use, ranibizumab, bevacizumab, or aflibercept. But the good thing they say, oh, aflibercept in some case that the vision is so low is good, but I think that the main message here is all of the anti-VEGF works. Doesn't matter if you use bevacizumab, that's supposed to be the one with less power to clean the edema, but does work, and that's cheap. And in Brazil we use a lot bevacizumab because the price. And if you have a good money, good cover, we can use aflibercept, but it's not easy to use aflibercept for everyone. And then if you take a look, after a while the patient starts to lose vision, even if you treat well, just because with all this change in the macula, sometimes we have some ischemic area, we have atrophy, and then can lose photoreceptor even with dry macula. The diabetic is not easy to treat. Tomorrow we're going to talk about biomarkers that help you to predict the future of the vision in diabetic patient. But even with anti-VEGF, almost 40% of the patients do not respond well. They are resistant of the anti-VEGF. 40% is a big number. Look here. And what to do in these patients? Still inject or not? And this paper here that I'm going to present, Gonzalez they say, okay, if you do 3 injections, if it doesn't work, have to switch fast for another anti-VEGF, or just go for steroid or anything else. But Neil Bressler just published this something like 4 years ago. He said, okay, if you still inject in this patient here, that's very few gains after 3 injections. After 2 years, 40% of these patients are going to have more than 10 letters. They say, in many cases, to persist injecting, even if the patient doesn't respond well, may be going to be very good. But here's the same idea. These patients that doesn't respond well, we have to continue inject. But if you think that macular edema is not only VEGF, has inflammation, huge inflammation. And if time goes by, they have this table that shows you the beginning of the edema is driven more by VEGF, but after a while we have a bunch of other cytokines, that's inflammation cytokines. And because of that, steroids works. And the big question now, when to switch? After 3 injections, 6 injections, what's the best time to switch from anti-VEGF to steroid? And if you see Rise and Ride, that's everybody knows this paper, they say that if you postpone a lot to treat patients, they never gain vision. I think the same question can say if you postpone too much to switch drugs, because we're going to have atrophy, loss of photoreceptor. Maybe, personally, I used to switch between 3 and 6 injections. If it doesn't respond anything, maybe I'm just switch to, for example, bevacizumab to aflibercept after the force, but I don't stand too much waiting for this. I don't follow Neil Bressler paper that's gonna keep inject for 2 years and only 40% of the patients gonna get better. Usually between 4 and 5 injects, if don't respond anything, I switch to steroid. And this paper has confirmed this. They said that if you do switch this drug, you have the best vision of these patients. You don't have to postpone for 1 year and 2 years. Wait at least 4 to 5 injections, maybe 6 injections. If it doesn't have anything, switch the drug. Go for steroid or vitrectomy, anything else. And protocol V is very interesting thing, because if you have some edema and the patient is 20/20, maybe it's just follow this patient, try to make them very stable. I mean, the glycemic level and hypertension, and maybe these patients you're gonna follow for some time and they not change vision. And another thing that's very important is when you start to inject anti-VEGF, the patient does improve in diabetic retinopathy. Sometimes you have this non-ischemic patients, moderate, non-proliferative. You can get a patient like very low level. We can get 2 steps back when you start to inject, because they improve the whole system and the patients get much better. And these things, I start to rethink about vitrectomy in patients. In Brazil, we have a public system that sometimes don't pay you for anti-VEGF or anything, and what to do. In many patients, I start to do vitrectomy. And Hilly Lewis, in '92, they said vitrectomy for diabetic macular edema does work because they relieve all the traction, remove the cytokine, and increase oxygenation. And this can help a lot. When you have traction, no question, we have to do vitrectomy, but we have persistent and you have no money to switch for Ozurdex or any other different drug that's more expensive, maybe just go for vitrectomy and remove the internal limitant membrane, and you have very good results with that. Here it's a trial that was published something like 4 years ago, 120 patients, and 43 patients got 5 letters and 30% got 10 letters. But the good thing about this trial, they just say that if you decide early, you decide to switch for vitrectomy, you have the better vision. Why this? Because when time comes, it's still the edema, we're gonna lose all the cells, all the photoreceptors and everything. Just you can't postpone too much to change the way to treat these patients. And then if you don't treat well, you can get the drill, that disorganization of the inner layer. That means that you destroy all the cells that has to carry all the vision signals. That you do know, if you lose the layers of the inner retina, that means that even if you improve the edema, the vision will not outcome well. And then we have many other biomarkers that predict that vision, but one that I have to tell you, if you lose the external lines, the external limitant membrane, the ellipsoid membrane, these two lines, if you lose, like here, doesn't matter if you clean all the swelling, this patient will not improve. And then this is a PET survey in the Brazilian Retina Society that was 5 years ago. And even there, everybody tried to start with anti-VEGF, but when you talk about after 3 or 4 injections, everybody moves to Ozurdex, steroid. Very few people trying to do vitrectomy because they are not thinking that's the best way to do. But I believe that vitrectomy is a good way if you don't have a chance to go for steroids, or if you don't have any other way to treat, vitrectomy does work. And then laser is still good for many situations. Photocoagulation is still working. Aflibercept maybe is the best one, but all the others anti-VEGF work as well. Steroid I don't use at the beginning, not my primarily choice. Surgery, sometimes I use a lot because when I don't have money to switch drugs or anything I have to do. And the biomarkers, it's good because you can talk with the patient, the prediction if this patient is going to improve or not. And then I have to thank more on time to be here. This is a kind of fort that's happening in a lighthouse in my city that's very popular. And I hope you can continue this friendship and exchange a lot of science and culture. Thank you so much. Sorry, I just forgot to introduce myself. My name is Jorge Rocha. I'm from Brazil, and I don't live in São Paulo, Rio de Janeiro. That's a very popular city in my city. I live in the northeast of Brazil, the city of Salvador, the first capital of Brazil. It's very popular about the carnival, not real carnival, but my carnival. And my background, nowadays I'm working with many societies. I'm the general secretary of the biggest society in Brazil, that's the Council of Ophthalmology in Brazil, the CBO. I'm also general secretary of the BRAVIS, Brazilian Macular Retina Society, and I'm the board of the Retina World Congress. That is, I'm working in the communication and organize all the course. And I work in a private practice. I have an institute. I'm president of the Retina Eye Institute, and I think it's okay. Thank you. Thank you very much.
Thank you very much, Dr. George Rocha. Now I would request Dr. Muhammad Al Amri from UAE. Please come over.
Assalamu alaikum wa rahmatullah. Good morning to you. I am Dr. Muhammad Al Amri, ophthalmologist, consultant. I am working in United Arab Emirates. I am originally from Yemen. I think you know Yemen now, very famous because they are very good people. They are killing themselves, so they are very nice. I am the president of MIOM Academy, which is Middle East Ophthalmology meetings. Also, I'm the founder. We are conducting a conference. Also, I am the vice president of and the founder of QUIC, Qasimi Ophthalmology International Conferences. Also, I am one of the founder of the Gulf Retina Group in Gulf area. Also, I am a member of UAE Right Foresight Committee. I am mainly a medical retina and anterior segment surgeon. Thank you for this kind invitation. I would like to thank my dear friend Dr. Hussein for these invitations. So I will start my talk because I was thinking I will talk about the fluid and the role of the fluid in diabetic macular edema. You know the fluid. I think most of you, I think here they are working in in diabetic retinopathy or medical retina. So there will be an accumulation of fluid in the layers of the macula. And that's, you can see in the first one, there will be a normal. In the second one, you can see the abnormalities when there will be an accumulation of fluid. DME is characterized by abnormal accumulation of fluid in the interretinal and subretinal space, causing the retinal thickening and leading to distortion of the central vision. In AMD or DME, you can find that there will be a result of disruptions of blood retinal barrier. However, the primary location of disruption differs in the two diseases. You can find that in DME is initiated by breakdown in the inner blood retinal barrier, while in neovascular AMD there will be an outer disruption in the outer blood retinal barrier, and there will be also a disruptions and breaking in the junction between the retinal pigment epithelial cells, while in the retinal diabetic macular edema there will be disruptions in the interendothelial junction in the blood vessels itself. As you know, there will be a lot of different types, so there will be an intraretinal fluid or subretinal fluid, and my talk today I will concentrate only on about diabetic retinopathy. At baseline, the intraretinal fluid most predominant retinal fluid, so you will find it in most of the time in about 100%, we can say, because they are mentioning about 95, 94, but so you can find intraretinal fluid almost in about 100%, and it was shown that in protocol T or in the Vivid and Vista as a study for the aflibercept approval, and also in another real-life Apollon study also it was showing that. And the subretinal fluid represent about, it varies from 25, and some in other studies may reach to about 40%. So the role of retinal fluid type in DME, subretinal fluid, as we say, it is the most common one. The intraretinal, the subretinal is represent about 40%, as we mentioned. It's considered to appear relatively late during the course of the disease itself. So most of the time we are seeing the intraretinal fluid. If untreated, subretinal can lead to a loss of vision in DME. So, and it was shown in the RISE and RIDE post hoc analysis that patients with subretinal fluid are at the baseline, they are 4 times likely to experience loss of vision more than 15 layers from the best corrected visual acuity. Subretinal fluid is associated with worse baseline best corrected visuality. Reduction in subretinal fluid leads to improved vision And this is our aim of our treatment. As Dr. Ruka mentions, that before we used to only treat our patient by laser for the last maybe 30 years, but when the era of anti-VEGF came, so we are promising the patient at least we can stabilize the vision, and sometimes we can improve the vision up to 10 or 15 letters accordingly. But before in the laser era, we are trying just maximally to stabilize, but in maybe about 60%, they are even losing of the vision more than about 10 letters or more. Intraretinal fluid and cyst, this is very important because sometimes the intraretinal fluid, it comes in different form, and one of them is cyst, and cyst one of the most difficult one to treat. Sometimes you are giving, especially if it is in the center, and you can find this in the cyst here. That kind of cyst is more difficult, and also it may lead to a less response to the anti-VEGF. If untreated intraretinal fluid, the macula associated with poor visual acuity, and that I have mentioned to you according to the RISE and RIDE protocols. Intraretinal fluid at the baseline or during follow-up had a negative associated with visual functions. According to the protocol T, the presence of intraretinal fluid baseline was associated with worse baseline base-corrected visual acuity. In DME, the center involvement intraretinal fluid and subretinal fluid is one of the have a poor prognosis, and we know that because sometimes if we have around the macula, we can say 1 disc diameter. Sometimes even as Dr. Kami can treat it only by laser, focal laser, but it should be away from the center. This is very important because nowadays we are afraid of fibrosis and another complication of the laser. But if it is in the center and if the vision is associated with good visual acuity, we are the most important to advise our patient to a good control of diabetes mellitus. Then some of them, and we have collected many patients like that, and we have published one paper about that. So many of them, they are very well respond, and you can find, you will be astonished that most of them, they come after 1 month or 2 months with good control of blood sugar. They will become a good and no macular edema at all. But if there is a persistent after a good control of blood pressure, then we can proceed for the anti-VEGF accordingly and according to what you have in your country. Chronic and persistent macular edema. Also, chronic macular edema can lead to irreversible damage of the macula and permanent visual loss. And it can be to mainly to the ischemic changes that happened during the period of. That's why maybe, I don't know, there is a debate about when to switch, but it's vary from one place to one. For us now, we are not late than more than 3 injections. If there is no response, so we have to define what is non-responder patient. If there is no any improvement in the visual acuity more than 5 letters, or the improvement less than 5 letters, or there is no less than 100 micron decrease in the central retinal thickness, then this patient, we are considering them, they are not responder, and is the best way you have to shift. And also, I am not of the believer to switch to another anti-VEGF. We can go directly to the steroid. And maybe I will have another 2 presentation about the role of steroid in the management of diabetic macular edema. And I have experience with either Ozurdex or Iluvien for a long period of time and many injection of that. But nowadays, there is a new molecules of anti-VEGF, either brolucizumab or faricizumab, and they are also promising, and they are making a difference, and they are playing a good game in management of diabetic macular edema, and they are very strong in the drying of the macula. And so I think now we can say we can switch between brolucizumab, between the previous anti-VEGF, either Lucentis or Eylea, to faricizumab or brolucizumab. But before aflipercept or Lucentis, we are not anymore switch between both of them. Just we are moving from any one of them directly to the steroid. Sometimes we are in our area, we are not allowed to use Avastin. It's not allowed anymore. So it's off-label, so we are only using either Lucentis or aflibercept. There was a significant proportion of DME eyes continue to have persistent fluid, and they are showing here if it is according to the protocol eye. So if it is in only in the first 12 months or 1 year, you can find it's 81% they will have about diabetic macular edema persistence. If we go 24, you will find it will be decreased because we are continue treating. And there will be a 40% with persistent macular edema. It can be seen in about after 3 years. But this one, you know, no one can wait this long time for the patient, because if you will wait, then we will suffer that we cannot improve the visual acuity. After that, maybe we can dry the macula, but the patient, he is not looking for the dry macula. He is looking about the vision. He will improve or not. After that, so we can dry the macula by new molecules, but the patient is the same. So you will have, and you will in our people, and I think maybe here in Pakistan they are not different than us. So patient doesn't care about what you are going to explain. If there is a drying of the macula, you have to give him a promising of the visual acuity. And this is all his question. I'm going to see. If he's not going to see, even sometimes the changing or switching early, it's make difference, because sometimes will not come. You will lose the patient because after 1 injection, no improvement, second injection, no improvement, third injection, no improvement. Then after that, he will not come. This is one of the most important also compliance that we are suffering with our patient. I think it's the same we are talking. Longer duration also increase the duration of edema. Also, it may lead also to a poor visual acuity gain and decreasing the central retinal thickness. So it is the same, we are talking about the same. So fluid in DME, fluid accumulation, disrupt this as a conclusion, architecture of neurosensory unit, and lead to a retinal dysfunction with patient eventually expressing visual loss. Early treatment is important in DME to achieve optimal visual gains. Intraretinal and subretinal fluid associated with worse baseline best corrected visual acuity in DME. DME patients with persistent fluid have lower visual gains compared with those who have achieved early resolution, and that's why we are recommending an early switching. Reduction of intraretinal fluid and subretinal fluid is associated with improved visual outcome in DME. All fluids is pathological or not. Also, this is a debate. Some of them, they are saying we can forgive to have some amount in diabetic but not in AMD. The other, they are saying the opposite. Maybe this one, it can be a part of the discussions between the panels. This one is okay. And finally, I would like also to welcome you all to our 5th MIOM conference, which is Middle East Ophthalmology meeting. It will be 20 to 22 of October next year. Thank you very much. And any question ready?
Thank you very much, Dr.
Thanks.
Hello. Very nice talk. And one thing that's you talking about the new moleculars, brolucizumab. The brolucizumab is something amazing. They dry more than any others, but we have problem with the vasculitis. And in Brazil, we stopped to use for macular edema. Use only in some specific macular degeneration case. You still use brolucizumab for macular edema here, because there we stop completely.
I will have also a talk about the role of brolucizumab, another one, but here I will give you a very short. I have a good experience in treating the AMD, which one is having a higher percentage of intraocular inflammation. I think we are exaggerating. There is an inflammation, there is no doubt, but the vasculitis is less than 1%. I mean, you cannot prevent your patient to improvement because there is 1% chance to be vasculitis. That vasculitis can be treated. And at the same time, now the DME treatment with brolucizumab, the approval study, it shows different. I don't know, you are aware about this one. So why it happened, and there is discussions now, why in AMD we found that number, high number in vasculitis or intraocular inflammation, while in DME, in the approval study, and there was a post-hoc analysis also about that one, and there is no inflammation even equal to the aflibercept. I have so many cases in AMD, and I will show you even I have used it in a naive patient. This is my talk, it will be a naive patient, not even a switch, and they are very nice actually. I feel sometimes, you know, you are stuck, you are not able to do anything, and it is available molecules, one of our weapons that we can use to treat either AMD or DME. I'm not that afraid you have only to have to take care, follow up of the patient, select nice the patient. You can never say, I mean, endophthalmitis can happen with any intravitreal injection, which is equal 1% of vasculitis. So we have to stop all anti-VEGF. In this case, this is my opinion about this one is justification, because sometimes steroid, they are most of the people afraid of steroid because of intraocular pressure or because of the cataract. That's okay, you have to give and you have to treat. If anyone here, they are not ophthalmologists and they are internal medicine, you can say 50% of their treatment, they are depending just throwing the steroid, and they are give it to you, and they are more stronger and more high dose and more side effect. But still we have to use it, but with cautious and just follow up of the patient.
Thank you very much. Thanks a lot for such an elaborative talk. Our next speaker is Dr. Amreen Gul. She's talking about safety and clinical efficacy of suprachoroidal triamcinolone in persistent macular edema. Dr. Amreen Gul, please.
Thank you so very much, sir. So, refractory diabetic macular edema, the role of suprachoroidal triamcinolone acetonide. Diabetic macular edema, as we all know, is the leading cause of decreased central vision in patients with diabetic retinopathy, and mainstay of treatment these days is intravitreal anti-VEGF agents. Compliance, cost, need for repeated injections along with poor response in some cases limits their effectiveness. Steroids are the second agents due to the side effects of cataract progression and raised intraocular pressure. Steroids have anti-inflammatory, anti-angiostatic, and anti-permeable properties. So, a recent increase in interest is to explore the biodegradable implants that slowly release the drug into the eye. But their cost and availability limits the use in Pakistan, in developing countries particularly. Intravitreal injection steroid is effective in resistant diabetic macular edema, but they have limitations of complications because these are the invasive and they can be associated with complications like retinal detachment or endophthalmitis. And these drugs actually flood the whole of the posterior segment with the drug because the injection is being injected into the intravitreal cavity. So the foremost challenge on ocular drug delivery research is development of safe and efficacious route for posterior segment pathologies. Now, suprachoroidal space is a novel investigational route of drug administration between the sclera and the choroid, targeting the sites of therapeutic drug action within the choroid, the retinal pigmented epithelium, and the adjacent retina. Sufficient therapeutic concentrations and high bioavailability in posterior segment compared to anterior segment reduces the side effects of risk of cataract progression and raised intraocular pressure like glaucoma. So the purpose of our study was to evaluate the clinical efficacy and safety of suprachoroidal injection triamcinolone acetonide in cases of resistant diabetic macular edema. Now, it's an ongoing prospective interventional clinical trial, and we included the patients of phakic eyes of type 1 and type 2 diabetics, aged 25 to 80 years, resistant diabetic macular edema with a central subfield thickness of more than 300 microns meter and a best corrected visual acuity of less than or equal to 6/9, which is equivalent to 0.20 logMAR chart. And we excluded the patients of macular ischemia on fundus fluorescein angiography, vitreomacular adhesion or traction, diabetic macular edema with epiretinal membrane on OCT, any history of intraocular surgery or periocular steroids in past 6 months, and we also excluded the patients who had the intraocular pressure more than 21 millimeter of mercury. So, refractory diabetic macular edema patients were enrolled through the diabetic clinic, and they had a central subfield thickness of more than 300 micron meter after 3 or more injections of intravitreal anti-VEGF agents, and they had either no or less than 30% decrease of central subfoveal thickness, or no or less than 5 letters gain in best corrected visual acuity. Suprachoroidal triamcinolone acetonide was injected 3.5 millimeter away from the limbus in a dosage of 4 mg 0.1 ml in suprachoroidal space using 1 cc 30 gauge disposable ready to go syringe. So, these are the few images of the suprachoroidal injection needle, which is ready to go 30 gauge needle, and it has a 1 millimeter tip exposed, and when it is entered perpendicularly 3.5 or 4 millimeter away from the limbus, either in the supratemporal or infratemporal quadrant, it actually, the 1 millimeter tip exposed stops at the base of the sclera, and when the drug is being injected, it opens up the suprachoroidal space, and from there the drug diffuses into the retina and the choroid. So I have a short video over here. This is the injection triamcinolone being opened. This is the ready to go 30 gauge disposable needle. It has a 1 millimeter tip exposed. 4 mg of triamcinolone 0.1 ml is filled. After cleaning the eye and installation of 5% povidone iodine into the conjunctival sac, the topical anesthesia is being given. 3.5 millimeter distance is measured from the limbus. Supratemporal quadrant is being marked. The bevel is kept away from the limbus, and it is entered perpendicular to the sclera, and you can see a small dimple into the sclera when needle is being entered, and then the drug is injected in a dosage of 4 mg 0.1 ml. All eyes were dilated so that we can ensure the patency of central retinal artery, and if any evidence of central retinal artery occlusion was seen, anterior chamber paracentesis was done. So post injection, antibiotic drops were given 4 times a day for 1 week for infection and inflammation prophylaxis, and patients were followed at first week, first month and third month for intraocular pressure, cataract grading, best corrected visual acuity, and central subfoveal thickness on spectral domain OCT. So, coming on to the results, mean age of our patients was 60.67 years with a range of 34 to 78 years, and mean duration of diabetes was 14.56 years with a range of 10 to 20 years. There were 2/3 males and almost 1/3 females, as can be seen in this pie chart. Majority of the patients in our study were type 2 diabetics, with 90% contributing the type 2 and 10% were the type 1 diabetics, as can be seen in this pie chart. So this bar chart is showing the previous number of intravitreal bevacizumab injections in these cases of resistant diabetic macular edema. The majority of the patients were falling in the category of 1 to 3 previous history of intravitreal bevacizumab injections, and with the almost 12 patients with a history of previous 4 to 6 intravitreal bevacizumab injections, and 10% of the patients were those who had previous history of more than 6 intravitreal bevacizumab injections. So the clinical efficacy was measured as the functional success and anatomical success, and the functional success was defined as measurable changes in best corrected visual acuity with more than or equal to 5 letters gain, and anatomical success was defined as central subfoveal thickness reduction by 30% or equal to or more than 100 microns meter. So this is the functional success. Mean pre-injection best corrected visual acuity was 0.8 by logMAR chart, and mean post-injection best corrected visual acuity at first month was 0.6 and at third month was 0.4 by logMAR chart. So these changes in best corrected visual acuity were statistically significant with a p-value of 0.001, which was less than 0.05, and improvement in best corrected visual acuity was seen in 28 patients, because those patients patients who had the chronic diabetic macular edema and the photoreceptor cells damage, they had the less improvement in the best corrected visual acuity. So this is a line chart depicting the pre-injection and post-injection mean best corrected visual acuity, and the topmost you can see over here is showing the pre-injection best corrected visual acuity, and the post-injection best corrected visual acuity is 0.4 at first month. So this is a statistically significant improvement in best corrected visual acuity. Coming on to anatomical success, mean pre-injection central subfoveal thickness was 940 microns meter by OCT, and mean post-injection central subfoveal thickness at third month was 305 microns meter, which was very highly statistically significant. An improvement in central subfoveal thickness was seen in almost all 30 patients, which was equivalent to 100%. This chart is showing the bar chart is depicting the mean central subfoveal thickness pre-injection, the red one bar chart, and the purple color is showing the post-injection central subfoveal thickness at third month. Now coming on to the safety, intraoperative and post-operative complications along with changes in intraocular pressure more than 21 millimeter of mercury and cataract progression were documented. Now the most common intraoperative complications was the eye pain, actually, which was experienced in almost 27 patients, and the subconjunctival hemorrhage, which was seen in 4 patients at the site of injection. Coming on to post-injection complications, anterior chamber inflammation was seen in our 1 patient, and intraocular pressure spike was seen in 1 patient at third month after the injection, while suprachoroidal hemorrhage, choroidal detachment, retinal detachment, or endophthalmitis was not seen in any of our patients, and almost 28 patients had no post-injection complications. So coming on to changes in intraocular pressure, which is very important when we are injecting periocular steroids, mean pre-injection intraocular pressure was 13.4 and mean post-injection intraocular pressure was 13.13 at first month, and at third month it was 13.10. So there was no statistically significant difference in intraocular pressure between the baseline and post-injection intraocular pressure at third month at p-value was more than 0.25, which we can see over here. It was 0.487. So this is a line plot showing the changes in the intraocular pressure, mean intraocular pressure, pre-injection and post-injection, which was not statistically significantly different. Now coming on to progression of cataract, which is actually the second side effect of the periocular steroids when we are actually injecting. So there was no statistically significant difference in grading of cataract seen pre-injection and post-injection at third month. And this is the bar chart depicting the grading of cataract measured pre-injection, post-injection first month, and post-injection third month. So grade 1 cataract was present in almost 28 patients pre-injection, and grade 1 cataract was present, almost the same degree of cataract was present post-injection third month in the same number of patients. So the few cases which were actually enrolled in my studies, a 56 years old woman known type 2 diabetic for last 15 years who had bilateral moderate NPDR with diabetic macular edema and the best corrected visual acuity of 660. Received 6 injections, both eyes previously, of intravitreal bevacizumab, poor response to treatment. She was actually also non-compliant as there was no response, and affordability issues also. So you can see over here, this is the pre-injection OCT and pre-injection color fundus photograph. Sorry for the poor view of this color fundus photograph. And this is the post-treatment OCT at third month. Now coming on to my second case, 65 years old male known diabetic for 20 years, bilateral moderate NPDR with diabetic macular edema in the right eye. It was given 5 intravitreal bevacizumab injections right eye, can't afford further injections, and hence lost to follow-up, then presented again, came back with the best corrected visual acuity of 636. This is the pre-injection OCT and the post-injection OCT at third month. Coming on to my third case, a 75 years old male with a proliferative diabetic retinopathy and diabetic macular edema, known diabetic for 20 years. Best corrected visual acuity of 660 and received intravitreal bevacizumab, both eyes, total 7 injections, was advised injection ranibizumab, can't afford So was injected suprachoroidal injection triamcinolone. It's the pre-injection and the post-injection OCT. This is the pre-injection and post-injection OCT of another patient enrolled in this study. This patient actually didn't have significant improvement in the best corrected visual acuity. A significant disruption of the photoreceptor layers was there, pre-injection and post-injection OCT. So pre-injection, post-injection OCT of another patient of left eye, diabetic macular edema. So what these all patients have in common, they have received multiple injections of intravitreal bevacizumab. They were not actually, they had the poor response in both anatomical and functional response. They can't afford further intravitreal anti-VEGF agents. They can't afford the ranibizumab injections. There was low compliance, loss to follow-up. So that's why these all resistant diabetic macular edema cases were enrolled in our study. So what this study added, 13 letters gain in best corrected visual acuity post suprachoroidal triamcinolone acetonide. Reduction in CST at 3 months was higher than the previous studies. The Hulk trial actually has the initial CST less than our study, because our study had initial pre-injection mean CST of 905, more than 900 microns meter. So this was actually explained because the initial CST was higher, so the reduction in CST at 3 months was actually higher than the previous studies. And only one case of raised IOP was reported, whereas in Hulk trial, 2 cases of raised intraocular pressure was reported, and 2 other studies reported no increase in intraocular pressure post suprachoroidal injection. And this raised intraocular pressure was treated with topical anti-glaucoma medications. Now coming on to the conclusion, suprachoroidal triamcinolone acetonide leads to anatomical and functional improvement in cases of resistant diabetic macular edema. A single injection was safe and effective in improving OCT macular thickness and best corrected visual acuity with no recurrence up to 3 months. But our study has certain limitations. It's an ongoing prospective trial, so we are still enrolling further patients and we are still following our previous patients also. Currently it has a small sample size and a short-term follow-up, and we don't have any control group in our study. So recommendations are controlled use of suprachoroidal triamcinolone acetonide is recommended in expert surgical hands in cases of resistant diabetic macular edema. There should be optimal timing of switch of treatment regimen from intravitreal anti-VEGF agents to steroids. If a patient is not responding to anti-VEGF agents, and that timing is very important before that diabetic macular edema being converted into chronic one with the photoreceptors damage, which will actually lead only to anatomical improvement but not the functional improvement. And treatment should be individualized for each and every patient. These are all my references. Thank you all for patient listening. That's all from my side. If any questions, there
Thank you very much, Dr. Amreen. I have 2 questions.
Yes, sir.
Number one, that did you go to check steroid responsiveness for by giving topical steroids in such cases before injected triamcinolone?
Steroid responsiveness?
Yeah.
No, sir. We didn't assess. So that could be.
Anyhow, it's my routine. If such patient comes, I usually start topical steroid QID for at least 1 month.
Okay.
You come to know that the patient has steroid responsiveness or not. Once you see the patient is steroid responsiveness and you give the triamcinolone, whether suprachoroidal or intravitreal, there will be disaster.
Yes, sir.
Sometimes you have to remove all that. And the
Okay.
second thing is, you mentioned that in complications, one patient got inflammation.
Anterior
What
segment.
sort of inflammation? Was it scleritis, surgical induced, or needle induced, or it was uveitis?
Sir, it
And
was-
why that occurred? Because the steroid uveitis should not occur after
Exactly,
giving
sir.
triamcinolone.
It was really surprising for us, because on first post-injection day, we were actually following on the first post-injection day also. And on first post-injection day, patient had anterior chamber cells and flare, ACM cells and pressure. That was actually anterior uveitis, almost +3 cells. And we
How,
get
how that was controlled after giving antibiotics or steroids?
So we were giving only the topical antibiotics post.
Yeah, that's very okay. I wanted to know that. Thank you very much.
I have, I have two questions for you. Congratulations, very elegant paper. The first thing is the efficacy you have shown 3 months, much better than inject intravitreous, that's 2 months decline. And when you predict to re-inject every 3 months, every 4 months, how, what's the optimal time to re-inject the steroid? And how to know that the steroid is really in the suprachoroidal space? Do you have any way to assess this? And what the company that produce that specific syringe and needle? I never seen that, but the idea is very good because your paper shown that's the level of complications much less than to inject inside the vitreous cavity.
Okay.
Thank you.
Sir, your second question I would like to answer first, that how do you know that your needle is actually into the suprachoroidal space and the drug is actually being injected into the suprachoroidal space? We were actually using the needle which was a pre-made needle. Most of the centers are also using their own customized needles. That is, they make their own needle. This needle is actually prepared by eye care, and it has 1 millimeter, only the 1 millimeter tip exposed. So the coming, if we consider the average scleral thickness in the population, so when the 1 millimeter is actually inserted perpendicular to the sclera, that actually goes into the space between the sclera and the choroid. The needle is actually into the suprachoroidal space because only the 1 millimeter tip is exposed. And if we consider the extreme ranges of the population of the scleral thinning or the scleral thickening more than this, even then the average thickness actually covers that part. So when that 1 millimeter is actually inserted in perpendicular to the sclera and drug is injected, it actually opens up the suprachoroidal space. And this needle prepared by the eye care company has a plastic, actually the plastic covering at the hub. That covering is not mobile, so you can't actually enter the eye more than 1 millimeter. You can't penetrate it further, and it stops at the base of the sclera. And second, sir, the eyes were actually dilated. We dilated all the patients before the injection. So just to make sure of two things. One, the patency of the central retinal artery post suprachoroidal injection. And second important thing is the eyes were dilated to confirm any spillage of drug into the intravitreal cavity, or by mistake we entered the needle into the intravitreal cavity. So actually none of the patient was showing the spillage of drug into the intravitreal cavity, because if triamcinolone goes into the intravitreal cavity, you can see the drug residues into the vitreal cavity. And eyes were dilated, and we performed indirect ophthalmoscopy in all patients post-injection suprachoroidal triamcinolone. Sir, coming on to your first question, which was what is the optimal timing of repetition of injection? Sir, in previous studies, in HULK trial, actually they repeated suprachoroidal triamcinolone even before 3 months, if there was recurrence of edema or if there was no response. But we actually followed our patients for 3 months, and for 3 months we made this thing as our protocol, that we will not repeat a steroid injection before 3 months. If after 3 months a recurrence will be seen, then we will be repeating a second injection of suprachoroidal triamcinolone. And sorry, sir, what was your third question?
Where could get the syringe? The specific
Sir,
syringe.
eye care is providing these syringes, and actually for Twin Cities we have made this syringe available opposite to Benazir Bhutto Hospital, which is my working place, opposite to BBH Hospital at Jawad Pharmacy. So it's quite available at quite cheaper rates. They are providing this needle in 500 rupees. So if we compare the bevacizumab injection, if a patient is not responding to the anti-VEGF agents, this treatment is actually quite cost effective in developing countries if we compare this thing. Thank you so very much.
Just one more question.
Yes, sir.
Is this company, do they have a stall here?
Yes, sir, they have a stall here, and they are Lahore based.
It's not a stall here. Basically, it is Lahore based.
Yes, sir. Lahore.
And one of our colleagues, our trainee, has produced use a kit as well for that. Dr. Irfan Kamath. He is here, I can ask him.
Yeah, I think you would like to speak. Yeah, I'd like to speak because the idea is very good for undeveloped countries like us, and many patients can't afford Ozurdex. That's very expensive. I agree with you that the average of the sclera is 1 millimeter, but we have high myopic patient that's seen,
Yes,
or
exactly, they have
we
the
have
thin sclera.
patients hypermetropic that's more sick,
Thicker
choroid,
sclera.
and then these variations is not easy to predict that you are inside the suprachoroidal space, but the idea is perfect, and it looks much better than intravitreal that we can have cataract, hypertension,
Yes,
and
sir, exactly.
much less. If you think that you have to re-inject every 2 months,
Exactly, sir.
even before 2 months, intravitreal to continues with the efficacy. But it's very nice. Thank you so much.
One thing I would like to add up that intravitreal injection also, when we inject intravitreal steroids into the cavity, so actually they flood the whole of the posterior segment with the drug, and patient initial follow-up of the patient is satisfaction is not that much, because these residues keep floating in the vitreous cavity, and they come to you that I'm having more floaters than what you have done with my eye or this thing now. So in our previous study, when we were comparing two injections, posterior subtotal and intravitreal, so this was actually the problem with the patient. Thank you so very much.
Thank you very much, Dr. Amreen Gul. Now, I would like to invite our friend Dr. Shehzad Shafkat. He is a lead consultant in medical retina in Birmingham, UK.
Thank you very much, Dr. Javed. I'd like to thank Professor Moeen and Professor Khaqani for the invite, and it's great to be here. So I'm going to talk about our own experience in Dudley with the brolucizumab in refractory wet age-related macular degeneration. So these are all switch patients, that they're not treatment naive. I'm not talking about diabetic macular edema because brolucizumab got its National Institute of Health and Clinical Excellence approval for DME only a month ago. So very little is being used in the UK at the moment. So we know the scale of the problem. Third commonest cause of blindness the world over, and the most common cause of blindness in the developed world is wet macular degeneration. The commonest cause of partial sighted and blind registrations in the UK. Nearly 40,000 new cases of wet AMD every year in the UK, and a huge cost to the national exchequer. £540 million in 2016, and it's even more now. As the population is aging, it will put more and more pressure on the National Health Service to deliver treatments for wet macular degeneration. So I'm going to talk about brolucizumab, which is an anti-VEGF-A monoclonal antibody fragment, an extremely small molecule. They've only taken the most active part of the Lucentis molecule and developed it into brolucizumab. It took about 5 years of research on that molecule just to make it less immunogenic. It got its approval from NICE on 3rd of February 2021. Cost-wise, you can see it is quite an expensive molecule, but they kept it cost neutral with Eylea. That was the drug it was compared to in the pivotal trials. We've now got faricimab. One of our colleagues, Dr. Al-Amri, mentioned that, and I've got a talk on faricimab in the next section tomorrow. All anti-VEGF injections are sourced by the Department of Health at a much more discounted rate than what is mentioned here, and it depends on how many injections you use. So Moorfields Eye Hospital, which gives 40,000 injections a year, will have a different cost to our department that gave nearly 6,800 injections in a year. So the way we treat patients with wet AMD is that there's a loading dose of 3 injections, one a month for 3 months. Then there's a disease activity assessment visit at 16 weeks or 2 months after the third injection. And after that, we decide whether we're going to give the injections 2 monthly, a fixed regimen of 2 monthly injections like Eylea, or 3 monthly. It depends on physician discretion based on visual acuity gains and central subfield thickness gains. So this was, a gift for ophthalmology because, this was the first approved injection for 3 monthly or Q12 injection regimens. And the pivotal trials, Hawk and Harrier, between 51 and 56% of the patients could be kept at 3 monthly injections. So this was brilliant news for ophthalmology. If we talk of outpatient visits in the hospitals, ophthalmology has the highest number of OPD visits by any subspecialty in medicine. Following us shortly behind is orthopedics. And within ophthalmology, 55% of all hospital visits are for medical retina, 35% for glaucoma, and then so on. So you can see that it's a huge burden to see these patients, a huge burden on the health system, and a huge burden on society, because these are elderly patients. They have to be brought in by family members, and you can imagine about the carbon footprint of a hospital because of wet macular degeneration. So carbon footprint is a new thing which is coming. All the Western countries are thinking about how to reduce the carbon footprint of the hospital. And so anything that gives a more durable treatment with longevity will be welcomed as a savior. So these are the nice guidelines for treating patients with wet macular degeneration. They're no different from ranibizumab or aflibercept. Vision has to be between 612 and 696. There should be no permanent structural damage. And the lesion size has to be a specific size, and the vast majority fall in this category anyway. And there should be active disease rather than just scar tissue producing poor vision. So we were aware of the Safety Review Committee recommendations from the American Society of Retina Specialists, where this was highlighted in 2020, that there was a 4.4% risk of intraocular inflammation in the form of retinal vasculitis, vascular occlusions, or just severe uveitis with brolucizumab compared to aflibercept with a relatively quite good safety profile. So we made the decision in the department, as head of the department, I decided that we will only use it in a switch patient, not in treatment naive patients, that we will give it in the eye where the fellow eye has at least 6/10 vision, which is driving vision in UK, and that they shouldn't have any previous history of inflammation, intraocular inflammation in either eye. We also decided not to use it in any eye that was using more than 2 glaucoma medications to lower pressure if they were suffering from primary open-angle glaucoma or ocular hypertension. Because if we were going to use heavy doses of steroids to suppress inflammation in that 4.4%, then it wouldn't interfere with their glaucoma management. So our patient sample size is this. We were the first to use it in the Midlands region of United Kingdom. First injection was given on 9th of March 2021. To date, we've given 53 injections in 13 patients. But I'm only presenting here data on 10 patients who have had 4 or more brolucizumab injections. They have a 4 to 18-month follow-up period, and all patients had just one eye treated. So you can see here 5 patients have received 4 injections, 3 patients 7 injections, and 2 patients have had 8 injections, with the predominance of left eyes being treated. They were all switch patients. Minimum number of injections given before the brolucizumab use was 15 Lucentis. The maximum number of injections were 42. with 12 Lucentis and 30 previous Eylea injections. If you look at the findings of our small sample, basically vision gets stabilized after use of brolucizumab. The best visual gains, like most studies that you look at of anti-VEGFs, is in the first 3 months. So you have duration, duration in months here on the x-axis, and visual acuity, logMAR visual acuity here. And you can see the first 3 months there is improvement in vision, followed by stabilization. So this visual acuity chart shows the vast majority of patients had stabilization of vision or improvement. Only 2 patients where there's a minimum drop of 3 letters, that's like half a line of Snellen visual acuity at month 4 and month 6. But there were equally patients who had significant improvement of 1 line or more, like for example patient number 6, patient 8, patient 9. You will see significant improvement. Central subfield thickness, again, duration in months on the x-axis, and central thickness in microns in the y-axis. And you can see first 3 months significant improvement in central subfoveal thickness, followed by stabilization. So you can see it better in this chart. Only 1 patient, patient 4, had increase in central subfield thickness at month 6. All the other 9 patients had significant improvement. Particularly, I'll point out patient 1, patient 5, 6, and 9, who had very significant improvement in their central subfield thickness. Remember, these are all switch patients. They've all had Lucentis and Eylea for a long period of time prior to switching to brolucizumab. It's an excellent drying drug, and it's been alluded to by Jorge here and Dr. Alamar, that it's a fantastic molecule, very small molecule, small in size, 28 kilodaltons compared to Eylea, which is 97. So weight for weight, when you inject 0.05 ml, you are injecting 6 milligrams of brolucizumab compared to 2 milligrams of Eylea. So you're flooding the inside of the vitreous cavity with this, and so it goes and neutralizes the VEGF-A receptors on the endothelial cells. So sub-RPE fluid, you can see it got resolved in the majority of patients. In patient number 7 and patient number 9, it was still present at 6 and 15 months, but in the majority of patients it got cleared. Subretinal fluid, all the patients in blue is where it got cleared. Only patient number 4 and patient number 9, these were the 2 patients where it still existed at 6 months. And intraretinal fluid, apart from 1 patient where it appeared after 12 months, all patients had clearance of intraretinal fluid. Subretinal hemorrhage, there were 3 patients who presented with subretinal hemorrhage, and it cleared all of them, and I'll show you an example towards the end. So to summarize, promising results were seen in 4 to 18 months follow-up data, both in terms of visual acuity gains and central subfield thickness. The best improvement for both vision and OCT was in the first 3 months. 2 patients had a small drop in vision, half a line on Snellen. 8 had stabilization or improvement. Only 1 patient had increased central subfield thickness from baseline. So basically our small cohort matches the Hawk and Harrier trial data, where it showed that brolucizumab was non-inferior to Eylea at 6, 12, and now 24-month data is available as well. It's a superior drying agent, and in 6 out of 10 of our patients, we were able to maintain them at 3 monthly injections, whereas it was between 51 and 56% in Hawk and Harrier trials. One caveat is the serious adverse events. We had one case of moderate intraocular inflammation. It was seen after the 8th injection. No other cases of intraocular inflammation were seen. And this is that patient. So this is at presentation. Visual acuity is 0.8. This patient has had lots of Lucentis and Eylea injections. The scan goes through the center of the fovea. You can just about see the umbo there, and you can see a large collection of subretinal fluid. Obviously, there is, because it's a chronic switch case, there is some fibrous tissue formation here as well. And lower down, when you go through the hemorrhagic area, you can see a hemorrhagic PED, a large one and multiple small ones with some more subretinal fluid. This is the same patient after the 8th injection. Visual acuity has improved to 0.7. You can see this area here, complete resolution of fluid, complete resolution of the hemorrhage, and settling down of his PEDs. This is the patient, the only patient that developed inflammation. 3 days after the 8th injection, he rang us to say he's got flashing lights and floaters. So we got him in. He was found to have panuveitis with a few fluff balls in the vitreous, but mostly cells in the anterior chamber. He was given on an outpatient basis 2 hourly steroids. We used Maxidex and 60 milligrams of oral prednisolone, and he resolved completely within 5 days. So we obviously followed him up, and absolutely no problems at all. But obviously we're not going to use brolucizumab in him again. We will be shifting him to faricimab, which is now available in our department. So just to show you, this is more like what our patients had, but the iris data from iris registry in the United States has shown that there's a 0.9 or let's say 1% risk of severe occlusive disease, something like this occlusive disease with drop of vision to very low levels, or like this. But the vast majority of patients, when we say there's a 4.4% risk of intraocular inflammation, the vast majority of patients fall in this category of anterior chamber reaction and vitreous fluff balls. And as Dr. Alamar was saying earlier, it's a fantastic drug. It dries the macula out completely. The key here is communication between the patient and the department. The patients, we tell them clearly about the risk of inflammation. We tell them clearly, and they get an additional sheet, patient information sheet, about what are the side effects and what are the signs, danger signs that they should look out for, to ring us, and a telephone number to ring us to let us know if there's a problem, so we can get them in quickly, diagnose inflammation, and treat them. Obviously, if they come with something like this, they have to be admitted and given a bolus of intravenous steroid followed by further treatment. Thank you very much. I'll take any questions.
Please, question answers.
An excellent presentation as always. The only, quick question, do we know the reason for this severe side effect of occlusive vasculitis?
So yes, I think,
Just, you can repeat your question?
so I'll repeat the question. The question is, do we know about the pathogenesis of this intraocular inflammation? There's been a lot of work going on, and Arshad Khanani's group in US, they have published a paper in 2022. It's the iris registry and Komodo map follow-up of brolucizumab injections all over US. And they have come up with this figure of 2.4% intraocular inflammation, less than 1%, 0.9% risk of severe vision-threatening occlusive vasculitis. And they think it's a type 3 hypersensitivity reaction, antigen-antibody reaction to the drug.
And also, how difficult is it to persuade your patients in this? This is not yet fully available in Pakistan, and I personally find it difficult to convince patients to switch on to this. just because when they read about the side effect, they say that, you know, the occlusive vasculitis, no wonder it is, you know, less than 1% risk of having that, but it's a very serious complication. So how do you manage to convince your patients to switch to this?
So, sorry. It was easy for us to do it in the last 1.5 years. Now, with the availability of Freecimab, it will be increasingly difficult for us. I don't see a big future for brolucizumab in the UK now that Freecimab is available, because that's a 4-monthly injection. So the big, big point here was 3-monthly. Now with the Freecimab, which is a 4-monthly injection and no intraocular inflammation, I don't think it has a chance. So in the past, yes, we used to tell them about this. We used to, have a big discussion with them, but tell them that if you want something which can be given at a 3-monthly interval, that's the only thing that you have.
Hina Khan sir, I just had one question. With an occlusive vasculitis, it may be more convenient to kind of label it as an autoimmune reaction, but with the kind of vitritis and fluff balls that you're describing, is there a telltale sign that would differentiate it from infective endophthalmitis? And the other differential is it's got so much more complications if you were to inject steroids. So how do you differentiate?
So that's a good question. I mean, how do you differentiate between endophthalmitis and just relatively benign iridocyclitis? And this question arises not just with this injection, but any injection. I mean, Lucentis Eylea patients, we do get maybe about 2% of patients ringing and coming back with inflammation. The vast majority don't have any pain. They certainly don't have any hypopion. There's been one case report of hypopion in Freecimab patients, because Freecimab doesn't come preloaded. You have to draw it up with a syringe. Syringes, to make them smooth, have a silicone coating inside. So when we draw up the solution in a 1 ml syringe, and to get rid of the air bubbles, we flick it. That flicking process should be a tap rather than a flick, because if you do a firm flick, you can get some of the silicone coming off the inside of and that silicone gives rise to an inflammation in the eye. It's sterile inflammation. So I think the lack of pain, the lack of hypopion, but you should have high level of suspicion on all iridocyclitis patients.
I have one last question. Here.
Sorry?
In the
We are short of time now.
we are here.
Oh, sorry.
Very nice presentation. One thing, when you have very severe vasculitis, we have any biomarkers that predict if the patient's gonna preserve the vision or gonna lose the vision? Have any biomarker that we can tell, oh, this patient gonna go well or this patient gonna fail?
Okay. The answer is no. But if you are asking any predictors of inflammation prior to starting the treatment, then Khanani's group, they looked at the iris registry again to see if there was any predictor. The weak predictor was female gender. Most of the inflammations were in female patients. But a stronger predictor was previous history of intraocular inflammation in the last 12 months preceding the injection. So these are the two things to look out for.
My last question, what post-injection regime you use, especially topical steroid, and how much long time you recommended for prevent the periocular or intraocular inflammation, which is associated with injection?
We don't use any drops or any treatment post-op for any injection.
No steroid, even no steroid?
No, no steroids, no antibiotics.
Oh, thank you.
Thank you very much, Dr. Shehzad, for a very nice lecture. Now I will request Dr. Muhammad Al-Amri from UAE, please to come over. His topic is inflammation and wet AMD. Please.
So we will move a little bit from treatment of diabetic macular edema or AMD. Let's focus a little bit about diabetic retinopathy. This is a new era of the management. So we are all the time depending on, for diabetic retinopathy, it's only laser, PRP for a long period of time until now. But there is now a lot of talks on publications, study going on, and some of them they are already approved to treat the patient for diabetic retinopathy itself, sometimes associated with diabetic macular edema, and sometimes without even diabetic macular edema. I will not go through this all information because most of you I know it, but diabetes is a very big concern, and it is increasing worldwide and also in our area, because most of the time we are having a lot of patients that they are not coming and we are not discovering that they are diabetic only late. So, and the number of the patients will increase from 450 to 700 by 2040. And also the burden, it will be a very big issue, especially in developing country. It will increase from 760 to 845 billions. Prevalence of diabetes is projected increase worldwide. I would like just here to highlight that in our Middle East and North Africa, it will increase by around 100% or 96% from 55 to 108 millions. That will be increased within between 2020 to 2040. The percentage of the DME in UAE, actually, it was, we are, ranked before as number 10 worldwide in the percentage of diabetes. We are about 1 in 5, so 19%. In these days, we are improving. We are coming to number 15 country worldwide. As you know, most of the patients, and I am one of them, I just newly discovered that I'm diabetic, and the most important things came to my mind, I will lose my vision, I will lose my career. So this is, I am a person treating a patient for diabetic macular edema, but mainly it came to my mind, it's going to affect my vision. So, and this is something true. So 50% of all patients diabetic, they are mainly thinking of vision related to diabetes. 5 years outcome of pan-retinal photocoagulation versus intravenous ranibizumab for proliferative diabetic retinopathy. This is a randomized clinical trial, the CRNet. This one was shown in protocol S. From these 5 years, I know that I will not go through all these details, talking about the numbers and so on. But you can see here, there as in protocol S, visual acuity change over 5 years, and Lucentis 0.5 use and prompt PRP, and they found that they are almost similar result in visual acuity, but it is more better even improvement in the visual acuity, about 2 letters at the end of around, I think it's 2 years or 90 months, yes, around 2 years. In protocol S here also you can Lucentis offer a significant lower rate of vitrectomy. This is very important, I think, for vitreoretinal surgeon. So if you are treating patient with anti-VEGF, you treat patient with diabetic retinopathy with anti-VEGF, so the percentage of vitrectomy, it will be decreased, so it will be about 15%, while those they are treated by laser, they are more exposed and they are having around 22%. Also offers a significant less peripheral visual field loss, which is very important, as you know, because we are using laser, we are almost destroying the periphery and we are concentrating about the center. But when we are using anti-VEGF, we are having very less about that. This is a review articles by San Raffaele's University, Milan, Italy, and published in Annals of Mediclinic. And the result that all data agreed that in considering anti-VEGF molecule as a first line. This is a publications. I'm just mentioning. We can agree or we can disagree about that. To choose as a choice for the management of diabetic retinopathy, there is less treatment may have role selected advanced cases, and for those patients unable to guarantee enough compliance to intravitreal injection. So still there is a rule for the result, but I think it's there. It's still more common to use it, not as is mentioned here, but this is one of the article mentioned. The overall feels that laser approach might be avoided when perfectly planned anti-VEGF therapeutic strategy can be adopted. This is also evidence for improvement of retinopathy. Also, this is an evaluating of the patient for giving intravitreal. It was aflibercept on diabetic retinopathy progressions. Also, this was published in American Academy. Also, it was found also in Vivid and Vista, significant proportion of patients as post hoc analysis that treatment with aflibercept Q8 8 weeks lead to a significant improvement in diabetic retinopathy severity after only 1 year therapy in around 30% of patients. Further evidence, this is a post-analytic of protocol T, the conclusion that relevance at 1 and 2 years eyes with non-proliferative diabetic retinopathy, anti-VEGF treatment for DME may experience improvement in diabetic retinopathy. Because the aim was here to treat diabetic macular edema, and in the post-hoc analysis they found there was an improvement in diabetic retinopathy. Also in clarity, there is a clinical significance intravitreal improvement in diabetic retinopathy versus pan-retinal photocoagulations, and it was shown in this. This is a detail of the clarity. We will move just about it. The proportion showing a total disease regression at week 52 in comparison to the, which was very less in comparison to photocoagulations. This is, I will show you some cases I used to treat them for diabetic retinopathy. This is a 57-year-old male patient, known case of diabetic for 15 years, hypertensive, hyperlipidemia. In the right eye, the visual acuity was 0.1, and the left eye is counting finger, anterior segment within normal limit, and intraocular pressure also within normal limit. And fundus, there is a proliferative diabetic retinopathy and DME. This is a patient pre-injection. Actually, he was not treated with any kind of treatment. This is the time he came to me, and he was having a diabetic macular edema, you can see, and he is having also a proliferative diabetic retinopathy, and it was very difficult cases, and there is some sort of epiretinal membrane, maybe you can see it. So post-treatment with anti-VEGF, I give him several actually injection. This is a continuous treatment, around 7 injection I give in the first year, and you can see, I think you can imagine the difference in the improvement in both eyes. So I treat both eyes. Even there is an epiretinal membrane, and this one it can be asked or questions, we have to go for vitrectomy or not, but the patient improving very well about that one. We continue treatment about patient, and this patient received about 8 injection in the first year and 6 injection in the second year. And the right eye improvement in the visual acuity 0.4. I think you remember it was 0.1. And in the left eye, which is also very important for this patient, he was only counting finger, and he is now driving. I mean, before is, you can say it's a handicap patient, but now is become a driving, and he is changed his life only because of 8 injection in the first year and 6 injection. We don't have any problem to give any patient because all our patients are insured and they are get it freely for all these injections. Fundus both complete regression of proliferative diabetic retinopathy, OCT both eyes, very less central diabetic macular edema. This is another article published also in 3 November 2020 about reporting volumes 10 articles number you can see. This is about pre-operative anti-VEGF. This is also something we are giving most of the time pre-op vitrectomy injection. So what are the correct time? What is this one? In this article, this is actually not one, it's a group of more collecting articles, and they have done analytic about this one. And in conclusion, in summary, our study suggests that performing the anti-VEGF pre-treatment of pre-operative, it will be between 6 to 14 days. I mean, within 1 week. Some of the people, they give it 3 days, 2 days, but the suggested it should be 1 week to 14 days, and it shows that this give a best efficacy in improving the post-operative best-corrected visual acuity and reducing the duration of surgery and incidence of recurrent vitreous hemorrhage. It is all achieve satisfactory effect in reducing the incidence of intraoperative bleeding. And thank you very much. Any questions?
Thank you very much. Any question, please? We have only 3 to 4 minutes. If okay, thanks a lot, and thank you, participant as well. Now our session is over. The next team might be waiting.